Hello everyone, my name is Ziad Affas, one of the residents at Hereford Macomb Hospital. Today we'll be talking about endocarditis with no valve involvement, a case report of superior vena cava endocarditis. Basically, patients with end-stage renal disease will likely need a vascular access for hemodialysis, and that vascular access can increase the risk of bloodstream infections, including septicemia and valvular endocarditis, and also, in rare occasions, non-valvular endocarditis. Problems with ESRD patients, they have weak immune defense, and thus they may not show all the signs of sepsis. Here we report the case of superior vena cava endocarditis in the setting of MSSA bacteremia in an ESRD patient. Our case is a 49-year-old lady with a past medical history of ESRD on dialysis, presented to the hospital for 2 days of fever. At that time, she went to the urgent care. Blood culture was done. She was given antibiotics and sent home. However, her fever continued. Thus, she presented to the hospital 2 days later. Upon arrival to the hospital, her blood culture showed from the urgent care and showed gram-positive bacteria. Physical examination at that time showed the normal vital signs, but the area of the catheter was indurated and tender. Ultrasound was done for the area, showed an abscess, and cardiology was consulted at that time for TTE and TEE, given her positive blood culture for gram-positive bacteria. TTE was done and was negative. Therefore, a transesophageal echocardiogram was done after that, which showed a large mobile right atrial mass consistent with vegetation, which is attached to the lower junction of the superior vena cava and the right intra-arterial septum. The mass measured about 19 by 15 millimeter. The patient was transferred to another hospital for angiovac, and at that time she got that angiovac there, and the culture showed gram positive bacteria, MSSA, susceptible to cefazolin, and the patient was switched from vancomycin to cefazolin and was discharged home. After that, she followed up with a blood culture and CBC, and the CBC didn't show any signs of infection with normal white count, and also the blood culture didn't grow any bacteria. However, the patient refused getting a trans echocardiogram to confirm resolution and no any valvular problems at that. The pathophysiology of that is when the endothelium is injured, a pericatheter thrombus forms as early as within 48 hours, organizes into fibroepithelial tissue over the course of several days, and finally create an endothelial layer indistinguishable from the vein wall at 30 days that remains intact within the lumen of the vein even after removal of the catheter. For further discussions, the patients like this one who's on hemodialysis, they usually have a higher incidence of infective endocarditis compared to the general population. Although the left-sided endocarditis is the most common type of endocarditis, but 10% of endocarditis can be a right-sided. And that's mainly in patients with intravenous drug abuse, intracardiac device, central venous catheters. The right-sided infective endocarditis is associated with a better clinical outcome compared to the left-sided. And this is likely the consequence of multiple factors, including that right-sided infective endocarditis, patients being younger, less systemic embolization, and less drug-resistant infection, and that's why they are clinically better tolerated. Several reports showed that most right-sided endocarditis responds to the antibiotic therapy without complication from extravalvular extension, and mortality rates are generally less than 5% without surgery. So we conclude that clinical suspicion should always be high for endocarditis in patients with fever and having dialysis catheter. TTE can be negative a lot of times in these patients. Therefore, having a high index of suspicion should always be there in these patients. Non-valvular endocarditis, such as superior vena cava endocarditis, is a very uncommon presentation and is only documented in a few cases in the literature.